那接下来我们很快就进入我们的第一个 section 咯。We are going to go into the first section talking about amyloid and tau PET in Alzheimer's disease. We are very honored to welcome Professor Hiroshi Matsuda from Fukushima Medical University. We are also very honored to welcome Dr. Qiu Baiyi to be our moderator. Please, Dr. Qiu.
Thank you. Good morning, ladies and gentlemen. It's my great honor to introduce first speaker, Professor Hiroshi Matsuda. Professor Matsuda now is the professor of Department of Biofunctional Imaging of Fukushima Medical University, 福岛医科大学, and also the director of Drug Discovery and the Cyclotron Research Center of Southern Tohoku Research Institute for Neuroscience, 南东北神经科学研究中心. He is a famous neurological imaging expert in the world. He developed many softwares for analysis and interpretation of neuroimages, including SPECT, PET, and MRI. Today, he will give us a lecture entitled as Amyloid and Tau PET in Alzheimer's disease. Let's welcome Professor Matsuda.
Let me talk about amyloid and tau PET in Alzheimer's disease. Conflict of interest is listed. 5 amyloid PET tracers, carbon-11 PIB, fluorine-18 fluorobetapier, fluorine-18 flutemetamol, fluorine-18 fluorobetaben, and fluorine-18 flutafuranolol are currently available. Dose, waiting time, and imaging time are recommended for each tracer. Waiting and imaging times vary from tracer to tracer, ranging from 30 to 120 minutes and 10 to 30 minutes, respectively. Amyloid PET interpretation is based on visual reading of positive or negative findings. Non-specific white matter accumulation is regarded as a negative finding. Gray matter accumulation in 5 regions of interest, posterior cingulate gyrus and precuneus, frontal cortex, temporal cortex, parietal cortex, and striatum is regarded as a positive finding. Amyloid negative and positive findings in carbon-11 PIB PET at the cerebral level. Cerebral medulla shows high accumulation in both negative and positive cases. On the other hand, cerebral cortex shows very low accumulation in both negative and positive cases. At the pons level, pons shows high accumulation due to the high white matter content in both negative and positive cases. Diffuse accumulation in cerebral white matter is observed without any accumulation in cerebral cortex in a negative case. Temporal cortex shows high accumulation in a positive case. High accumulation is observed in ethmoid sinus, sagittal sinus, and capillary sinus in a negative case. Midbrain level. Frontal and temporal cortices show high accumulation in a positive case. On the other hand, hippocampus shows low accumulation even in a positive case. Basal ganglia level. In a negative case, internal capsule and corpus callosum show high accumulation. On the other hand, caudate and putamen show low accumulation. Globus pallidus shows higher accumulation than striatum because of higher white matter content. In a positive case, high accumulation is observed in frontal and temporal cortices and striatum. Occipital cortex shows a relatively low accumulation. Lateral ventricular body level. Posterior cingulate gyrus shows high accumulation in a positive case. Centrum semiovale level, precuneus and parietal cortex shows high accumulation in a positive case. Pericentral sulcus area shows relatively low accumulation. Mid-sagittal section. In a positive case, high accumulation is observed in medial prefrontal cortex and posterior cingulate gyrus and precuneus. A parasagittal section. Anteroventral striatum shows high accumulation in a positive case. Coronal section. Hippocampus shows low accumulation even in a positive case. To summarize positive findings of amyloid PET, high accumulation is observed in posterior cingulate gyrus and precuneus, frontal cortex, temporal parietal cortex, and striatum. Striatal accumulation is more pronounced in familial Alzheimer's disease. Low accumulation in pericentral sulcus area, occipital lobe, and hippocampus. Cerebral cortex shows lowest accumulation. You can see marked striatal accumulation in a patient with preselin1 gene mutation. Conversely, if such a conspicuous accumulation in the striatum is found, then familial Alzheimer's disease should be suspected. The diagnostic likelihood of Alzheimer's disease was evaluated before and after amyloid PET in 5 categories: very high, high, moderate, low, and very low. While high likelihood was most frequently observed before amyloid PET, 2 distinct categories were shown to exist after PET: very high and very low likelihood. It is important to note that only 79% of the patients who showed a very high likelihood before amyloid PET were positive on amyloid PET. Also, only 60% of those with a high likelihood had a positive amyloid PET. Overall, amyloid PET changed 73% of the likelihood categories for the clinical diagnosis of Alzheimer's disease. In visual reading of amyloid PET, lower concordance in fluorine 18 labeled tracers than that in carbon 11 PIB. In amyloid positive case, gray matter over white matter accumulation ratio is lower in fluorine 18 labeled tracers than that in carbon 11 PIB. This low contrast makes visual assessment of mild gray matter accumulation difficult. To help visual reading of amyloid PET, quantification of amyloid PET is proposed. Standardized uptake value ratio, SUVR, which is a ratio of specific accumulation over non-specific accumulation, has been conventionally used. On the other hand, Centroid scale is newer indicating stage of amyloid accumulation, calculated on the basis of carbon 11 PIB PET from 0 obtained from negative cases in young control subjects to 100 obtained from positive cases in elderly Alzheimer's disease patients. Centroid scale simplifies and expedites direct comparison of amyloid beta PET results across sites and studies, outlines the earliest thresholds of amyloid positivity, and defines the range of positivity in Alzheimer's disease, robustly quantifies, longitudinally changes and facilitates inter-tracer comparisons. You can see the difference between central scale 0 and 100 amyloid PET images. In a central scale 0 image, you cannot see any accumulation in gray matter. When estimating central scale, you have to follow the method put forward by the Global Alzheimer's Association Interactive Network. The subject PET is registered to the co-registered subject MRI. Next, the co-registered subject MRI is warped into Montreal Neurological Institute space. The parameters of the deformation field in this warping are applied to the co-registered subject PET for anatomic standardization. The SUVR is calculated from standardized subject PET counts in a reference region and in the global cortical target region. Finally, the SUVR is converted to central scale values using direct conversion equations for each PET tracer. For reference regions, whole cerebellum, cerebral gray matter, pons, and whole cerebellum plus brainstem, and a target region in cerebral cortex and striatum are shown for estimation of central scale as volumes of interest VOI. Out of these four reference regions, whole cerebellum is recommended due to the smallest variance and the largest effect size for calculation of central scale. Unlike the SUVR, central scale is a universal 100 level quantitative value that is independent of choice of a reference area. Unlike the SUVR, the central scale is a universal 100 level quantitative value that is independent of used PET tracers. Case groups with positive fluorine 18 fluid metamorph PET by visual interpretation are shown with central scale. In sporadic Alzheimer's disease, amyloid accumulation begins in the posterior cingulate gyrus and precuneus and frontal lobes, spreads to the temporal and parietal cortex, and finally to the striatum. Case groups with negative fluorine 18 fluid metamorph PET by visual interpretation are shown with central scale. What is the optimal cutoff value for determining whether a patient is amyloid positive or negative on the central scale? A number of studies have been conducted in this regard. Studies comparing antemortal amyloid PET with postmortal neuropathology findings suggest that a central scale of 10 or less does not show senile plaque, thus ruling out of Alzheimer's disease. A central scale between 12 and 20 shows moderate to frequent neuritic plaque in the CERAT classification, while a central scale of 24 or higher shows intermediate to high level of Alzheimer's disease pathology. A score of 26 or higher is in good agreement with visual assessment, and a score of 50 or higher correlates most strongly with the clinical diagnosis of Alzheimer's disease. The gray zone for visually equivocal assessment is between 12 and 30 on the central scale, the range in which amyloid beta can be detected at the earliest stage. It is believed that a skilled reader can determine a positive result even at 16 to 17 by visual interpretation. In terms of disease progression, 19 is reported to be the cutoff for reliable worsening of the rate of change on the central scale, and 26 is optimal predictor of progression to dementia after 6 years of PET. To calculate the central scale of amyloid PET, one has to run statistical parametric mapping on MATLAB and perform a lot of processing. Several software packages have been published to perform this series of processes accurately and effortlessly. Here we present AmiCont. This software is applicable to the 5 currently used amyloid PET tracers. It automatically calculates the central scale. It performs atomic standardization of PET for central scale calculation using MRI or CT of PET-CT. It also displays a G-score map compared to a database consisting of amyloid negative young healthy subjects. Here are the output results. SUVR and central scale are calculated. G-score maps compared to a database consisting of amyloid negative young healthy subjects are shown in brain surface and tomographic images. Photometamorph PET of a visually obvious negative case is shown here. The central scale is 0. The target buoy is indicated by a white line in the tomogram of the G-score map. Regions with a G-score of 2 or higher are shown in color, but are not included in this target buoy. Photometamorph PET of a visually obvious positive case is shown here. The central scale is remarkably high, 104. Photometamorph PET of an equivocal case by visual interpretation is shown here. No focally increased accumulation is present. However, somewhat diffuse increase of cortical accumulation is present. The central scale is 26. Posterior single gyrus and precuneus and the medial prefrontal cortex show significantly increased accumulation in a G-score map. This case may be diagnosed as amyloid positive. Photometamorph PET of another equivocal case by visual interpretation is shown here. Focally, somewhat increased accumulation is present in the precuneus. The central scale is only 1. However, high accumulation is present in the left precuneus in a G-score map. This increase is mainly present outside target buoy, circumscribed by white line. Although this case has focal increase of amyloid accumulation, this case may be diagnosed as amyloid negative by overall considerations. However, careful follow-up may be necessary in this case. Carbon 11 PIB PET of one equivocal case by visual interpretation is shown here. Right frontal cortex seems to show somewhat increased accumulation. The central scale is 19. Frontal cortex and the posterior single gyrus show significantly increased accumulation in a G-score map. This case may be diagnosed as amyloid positive. To become proficient in the evaluation of amyloid PET, combined use of visual, read, and quantitative assessments using central scale or G-score mapping is useful. MRI taken at the same period as in PET is necessary for accurate estimation of central scale in amyloid PET. However, the following issue then arises. Is it possible to use a low-dose CT of PET-CT when MRI is not available, or when a considerable time has elapsed between PET and MRI imaging, and there is concern about misalignment between PET and MRI? Standardized with success like MRI to a Montreal Neurological Institute space by statistical parametric mapping. CT-guided standardized amyloid PET image is almost identical to MRI-guided standardized image. Radiation dose of low-dose CT to head is only 0.4 millisievert. Low-dose CT provides almost equivalent central dose scale to MRI. However, somewhat low -1.7 on the average central scale as compared to MRI. Validation criteria in central scale estimation is R square should be over 0.98. Slope of a linear regression equation should be within 0.98 to 1.02. And intercept should be within -2 to 2 in comparison of the non-standard method without MRI with the standard method with MRI. In this low-dose CT-based method, showed slightly lower slope of 0.97. A direct comparison between MRI-based standardized PET and CT-based standardized PET using paired t-test by statistical parametric mapping. Warm and cool color scales shows higher and lower counts of CT-based images than those of MRI-based images, respectively. In the cerebral hemispheres, higher accumulation of CT-based standardized PET than MRI. It may have caused slightly lower central scale values. It may be concluded that low-dose CT of PET-CT can be used instead of MRI for anatomic standardization in determining the amyloid PET central scale, but this may result in slightly lower values. Another issue further arises. Is it possible to obtain the central scale by PET alone without using MRI or CT? We applied mean atlas template with 50 of central scale and adaptive atlas template of either positive or negative template to estimation of central scale by PET alone as a PET template for anatomic standardization. On visual inspection, the PET alone method appears to be almost as more anatomically standardized as MRI or CT. However, the central scale in the PET alone method differs significantly from that in CT or MRI. MRI-based method provides 79.3, CT-based method 78.8, but mean PET template provided 69.2, and adaptive PET template provided 91.9. PET alone methods using either of mean positive or negative template result in large errors in central scale estimation. Then we tried the use of another adaptive template that is generated from a linear combination of an amyloid negative and amyloid positive template with a weight W optimized by maximizing the normalized mutual information between the adaptive template and the target. In GAAIN dataset, this adaptive method provided much better correlation than the method using either of mean negative or positive template between non-standard PET alone method and MRI-based method. In other datasets from JADNI, ADNI, and ABLE studies, this non-standard method provided R square over 0.907 in all PET tracers. although there are some deviations from the validation criteria, except for NVIDIA 4694. Thus, the use of adaptive PET template generated from a linear combination of an amyloid negative and amyloid positive template may provide sufficient accuracy in central scale estimation when MRI is not available. Let us move on to the next topic. Amyloid PET using solid-state digital PET-CT. Digital PET-CT has higher spatial resolution than conventional analog PET-CT. When comparing carbon-11 PIB PET images between digital and conventional analog PET, high resolution with better contrast digital PET image provides more precise white matter and gray matter accumulation in an amyloid negative and positive case, respectively. I would like to introduce amyloid tracer that we are currently using for research. Fluorine 18 labeled flutaflanolol, the most superior fluorine 18 labeled amyloid PET ligand. It's less non-specific accumulation than other fluorine 18 tracers. Equivalent or superior to carbon-11 PIB with large dynamic range. It has been used in clinical trials as well as clinical studies because of easiness to detect very mild amyloid accumulation. You can see clear-cut negative and positive images for fluorine 18 labeled flutaflanolol, NVIDIA 4694. Shall we move on to the next topic, tau PET image using digital PET-CT. You can see the neuropathological evolution of tau deposition in Alzheimer's disease. Tau deposition first begins in the transentorhinal area and gradually spreads to the limbic areas and then to the cerebral neocortex. There is less accumulation in the pericentral sulcus area and occipital cortex. I'd like to introduce a tau PET tracer that we are currently using for research. Fluorine 18 labeled MK6240. It is a second generation tau PET tracer, the most used in the world. Researcher can be registered in a worldwide database, allowing registered users to download data from other institutions for research use. It has been used in clinical trials as well as clinical studies. It has a low off-target accumulation and shows high accumulation in 3-repeat and 4-repeat tau. Thus, it is an ideal tracer for Alzheimer's disease. However, it has a low accumulation in 4-repeat tau, which is observed in progressive supranuclear palsy or corticobasal degeneration. MK6240 has off-target binding to ethmoid sinus, retina, and meninges in the extracerebral tissues, and to substantia nigra. These bindings are related to neuromelanin and melanin-containing cells. These new amyloid and tau PET tracers provide more accurate classification of amyloid A, tau T, and neuron injury N profiles. These profiles lead to biomarker category of Alzheimer's disease. A-, T-, N- is normal Alzheimer's disease biomarker. A+, T+ indicates Alzheimer's disease. A+, T- indicates presence of Alzheimer's pathologic change, and A- indicates AD pathologic change. We will now present cases using these amyloid and tau imaging using a digital PET. The first case shows amyloid plus, tau plus, and neuronal injury plus. Amyloid central scale is 59.4. Tau PET shows accumulation in bilateral medial temporal lobes and right temporal neocortex. MRI shows medial temporal lobe atrophy. This case is diagnosed as Alzheimer's disease. The second case shows amyloid plus, tau plus, and neuronal injury plus. Amyloid central scale is 70.7. Tau PET shows accumulation in bilateral medial temporal lobes and right side dominant bilateral temporal neocortex. MRI shows medial temporal lobe atrophy. This case is also diagnosed as Alzheimer's disease. Tau accumulation in the medial temporal lobe is observed mainly in entorhinal cortex and amygdala. Low accumulation is observed in hippocampus. In sagittal section, this accumulation pattern looks like hook, so-called hook sign. Upper part of hook sign comes from amygdala accumulation. Tip of hook sign comes from Wunck's accumulation. Then lower part of hook sign comes from entorhinal and parahippocampal gyrus accumulation. This hook sign may arise from low accumulation in hippocampus. This brings up a new question. Why is hippocampal accumulation lower than entorhinal or amygdala accumulation in Alzheimer's disease when using fluorine-18 MK6240? Also in autopsy brain tissue, hippocampus shows lower binding to MK6240 as compared to entorhinal cortex or fusiform gyrus. MK6240 binds well to paired helical filaments, but not to tau oligomer. We may speculate the hippocampus has relatively more tau oligomers than entorhinal cortex. The third case, with impaired memory retrieval, shows amyloid minus, tau plus, and neural injury plus. Amyloid central scale is 0. Tau PET shows accumulation only in bilateral medial temporal lobes. MRI shows severe medial temporal lobe atrophy. This case is diagnosed as senile dementia of the neurofibrillary tangles type. Tau accumulation in medial temporal lobes is observed mainly in parahippocampal gyrus. In sagittal section, this accumulation pattern did not show hook sign. Senile dementia of the neurofibrillary tangles type is slowly progressive dementia with abundant neurofibrillary tangle in the hippocampal region. It is more common in the late stage elderly with onset of memory impairment. Neuropathologically, absence or scarcity of senile plaques throughout the brain. It is 3-repeat and 4-repeat tauopathy like Alzheimer's disease. It is referred to as primary age-related tauopathy, so-called PART. It is a background of SNAP, suspected non-Alzheimer's disease pathophysiology, in the differential diagnosis of Alzheimer's disease. The fourth case with preserved memory retrieval shows amyloid minus, tau minus, and neural injury minus. Amyloid central scale is minus 0.6. Tau PET shows no accumulation. MRI does not show medial temporal lobe atrophy. This case may be diagnosed as subjective cognitive impairment. The fifth case with impaired delayed recall in memory retrieval shows amyloid plus minus, tau minus, and neuronal injury minus. Amyloid in central scale is 9.4. Tau PET shows no accumulation. MRI does not show medial temporal lobe atrophy either. In this case, amyloid accumulation is observed only in small area of right temporal cortex. G-score map detected significant increase in this area. Based on the overall central scale, it should be an A-, but it could be the very beginning of preclinical Alzheimer's disease. Take-home messages. The outcome of amyloid PET significantly led to a change in clinical diagnosis of Alzheimer's disease. To become proficient in the evaluation of amyloid PET, combined use of visual read and quantitative assessment, central scale and Z-score mapping is useful. For accurate measurements of central scale, low-dose CT of PET-CT, or a combination of amyloid negative or positive PET template may be useful for atomic standardization of amyloid PET when MRI is not available. Second generation tau PET provides accurate ATN profiles in Alzheimer's disease. This concludes my presentation. Thank you for your attention.
Thank you, Professor Matsuda. There's a question for you. This is the Dr. Cai Xinxi from Neurological Department in National Taiwan University Hospital. She said, "Thank you for your great speech. Could you comment on quantitative analysis of tau PET? Any well-validated or developing method that could provide more objective data than visual assessment? What about the color and specific ROI for positive tau scan?" Please, Professor Matsuda.
Okay. First of all, I'd like to express my thanks to be invited to this symposium. It's a really great honor to me. And so it's a very good question. So we are now trying to quantify the tau PET trace accumulation. So it's not sure that the tau accumulation has a plateau. So in some area shows increasing the accumulation without plateau. So in that meaning, the method for central scale may not be applicable in this increasing accumulation. However, some kind of the central scale or may be necessary for tau accumulation quantification. So now we are trying to define the target volume of interest using the worldwide database. So maybe it's maybe possible to define the Alzheimer's disease specific volume of interest for Alzheimer's disease. So maybe the quantification like amyloid accumulation may be possible. So it's still ongoing. Thank you for your question.
Thank you, Professor. Is Dr. Tsai has further question or others have further question for Professor Matsuda? I have one question for Professor. You know, the recently famous dementia subtype called late, caused by TDP-43. Is there any study that using the amyloid PET or tau PET to study the percentage of the positive rate in late?
So it's also a very good question. So I'm not sure about the study using the new ligand for detecting the TDP43. So I think the present ligand does not accumulate to TDP43. So in that meaning, we cannot diagnose the rate using the PET. So maybe the next speaker, Dr. Higuchi, has some answer to this in this regard.
Thank you, Professor. There's another question for you. For the last case, centiloid scale is only 9, but finally defined as positive scan. Is this due to overt accumulation of right temporal lobe?
So its right temporal lobe shows a significant accumulation. So however, it's a very small area. So the overall central scale is only less than 10. So I'm also very confusing. So how to comprehend the figure out this phenomenon. So in my present opinion, so such a patient with a low central scale in the whole brain, but has some significant area, the positive finding should be followed up very carefully. So yeah, very annual follow-up may be necessary in such a case. It's my quick answer.
Thank you, Professor. Is there any other questions? If there is no more questions, we may move over to. Sorry, is there any attendee says anything? Any questions?
There's a message from Director Yan Ruofang. First, she thanks Professor Matsuda that to provide us to use the program EASY for brain perfusion SPECT since 2016, and it helps us a great deal to provide better perfusion image results to our clinicians. Also, she would like to ask to use the analytic program as you addressed for the amyloid PET. Do we have to do a specific phantom scan to standardize our PET data? Thank you.
Thank you. So I can help your measurement using my program, but in the present, we cannot provide this program to your country. So I'm very sorry. In some regulation.
Okay, thank you, Professor. So,
can you hear me? I'm Dr. Hu.
Sure, Dr. Hu, please.
yes.
Okay. Thank you very much, Professor Matsuda, for your wonderful talk. I have a question for you. For the clinical use, especially for the diagnosis of Alzheimer's disease, do you recommend EG score or CL score? I think CL score, like a quantitative score, is maybe more suitable for the outcome follow-up. But the EG score is maybe better for the diagnosis. What do you think? Thank you.
I think you mean central scale. Central scale is more suitable for the follow-up because it's independent of the user tracers. So the central scale may be becoming more popular in the world for amyloid accumulation quantification.
Thank you. Thank you, Professor. So is there any further questions?
Can I ask another question to Professor Matsuda? because I just asked, do we have to do phantom study to standardize the data, PET data, to use your analytical program, AmyQuant?
It does not need as a phantom study. So yeah, nothing, no need.
Oh,
Yeah.
okay.
Thank you.
You will do the normalization automatically.
Yeah,
in
automatically.
Your program,
Yeah,
right?
automatically.
Oh,
Yeah,
okay.
that's right.
Thank you very much.
Thank you, Professor.